It is the dog days of summer, and time for another Puscast, covering the first 2 days, actually the first 2 weeks of August 2009. I am your host. Actually, I'm not a host. I'm a Hostess Cupcake. Hostess Cupcakes. I sure love them frozen. Anyway, this is brought to you by Puswell LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your Uber hyperlinked electronic guide available at moremark.squarespace.com, where you will find the Mark Crislip multimedia empire. Since this is CME accredited, and after you've wasted a half an hour of your life listening to this podcast, you can take a quiz and get a half an hour of free CME. Thank you, Legacy Health. I have to mention my conflicts of interest. I don't have any. Now, I've said this intro a billion times, and I'm sick unto death of it, so go back and listen to old Puscasts if you want to hear the full version of this intro. I'm actually sick of hearing myself speak, which is an amazing thing for an infectious disease doctor. There's no physician who loves the sound of their own voice more than an ID doc. Be that as it may, the only thing I demand of my listeners, yes, demand, is to go onto iTunes and write me a glowing review. All the rest, to quote the worst song ever written, is dust in the wind. And now we will move on to the literature on this beautiful hot August day. Pete Townsend is a genius, no doubt about it, and he has declared through the WHO that the H1N1 pandemic is over. This infected a lot of human beings, and the question is why? Now, generally speaking, there are 2 amino acids that need to be altered to allow an avian influenza to become infectious in human beings. Now, this H1N1 did not have these amino acid mutations that one would expect, since the H1N1 is of avian descent. It has been recognized that the H5N1, the bird flu, is 2 mutations away, these mutations from becoming pathogenic in human beings, and it hasn't happened yet. Although, interestingly, what these authors discovered is there's a different amino acid substitution that has led to the H1N1 becoming resistant. Do you care? Well, 2 amino acid changes in the polymerase PB2, peanut butter 2 protein, which changes a glutamic acid to lysine at position 627, or an aspartic acid to asparagine at position 701, or usually allow avian influenza to become effectively replicated in human beings. Instead, at position 591 of the peanut butter 2 protein, there is a change. And when they induce this change in H5N1, it becomes more infective in mammalians. So perhaps that amino acid position 591 will allow H5N1 to have just a single amino acid change and hence get into human beings. The beauty of basic science research. I think it's cool. As long as we are on the topic of basic science, why are obese people more likely to die of influenza? And pregnant people as well? Well, as you may or may not know, obesity is a pro-inflammatory state, and obese people in general have more sepsis-related mortality. Well, it turns out that patients who are obese have less negative feedback in the form of adiponectin as a endogenous anti-inflammatory. They think that the possible reason is they die is as follows. The innate immune system of individuals who have low plasma levels of adiponectin is hyper-responsive to pathogens compared to patients who have high levels of adiponectin. Thus, the response of an obese person to H1N1 infection is more pronounced than that of a lean person, and levels of pro-inflammatory mediators are elevated. The absence of this negative feedback mechanism may allow the initiation of a cytokine storm. I hate that term. And the development of septic shock. End quote from the Clinical Infectious Disease article reviewing obesity, adiponectin, and H1N1 infection severity. This also, by the way, applies to pregnant women who also have low levels of adiponectin. It sounds like some sort of fruit, some sort of fatty fruit. I'd like to have a dozen adiponectins, please. Anyway, that's the basic pathophysiology of why both the pregnant and the obese may be more likely to die of H1N1. As we, and that's the royal we, have talked about in other podcasts, the incidence, or is it prevalence? Is it the prevalence of the incidence, or the incidence of the prevalence? Anyway, more people are getting shingles. As the elderly get older, which is what the elderly do, unless they die, they are no longer exposed to wild chicken pox in their children and grandchildren, and as such are not boosted. And so the older population, over 45 or so, are seeing an increase in shingles. What might be a complication of the increase in shingles that we're seeing? Let me think. Could it be Guillain-Barré syndrome? See? French accent. Guillain-Barré. This study looked at a huge number of people. They had 315,000 people who had zoster. This comes out of Taipei Medical University. And they compared that with 946,000 matched controls. Whoa. They found 78 patients with zoster went on to develop Guillain-Barré, 0.025%, and only 14 of the controls, 0.001%. That is about a hazard ratio of 18.37. So patients, at least in this study out of Taiwan, huge numbers of people, suggest that one of the risks for developing a Guillain-Barré may be the development of zoster. Now, whether it's cause and effect or a coinky-dink due to some other co-founding factor is yet to be determined. But given that zoster lives in the nerve roots of the spinal cord, you can see how activation there may cause the immune system to misidentify the CNS and give you the Guillain-Barré. Mais oui, c'est bon, oulala, tout de suite. A couple of seasons ago, Google did Google Flu. What they did is they did search terms for flu symptoms and correlated it well with actual cultures for influenza. And people searching for flu-related symptoms preceded positive cultures submitted to the state by a couple of weeks. So it was an early warning sign that influenza was on its way. The Swedes did a similar thing. They looked at the search term vomit submitted to a Swedish medical site and correlated it with the number of submissions for norovirus. That's norovirus. This is Elmer Fudd giving you your Puscast. And they found three things. They found that vomiting searches preceded the onset of norovirus infections by several weeks. They also found that the curve for web queries was much more sharp, and the decreases sharper than the norovirus submissions to the state. And they also found that the search behavior was not associated with what they call the winter vomiting disease. I don't know what that is. Maybe that is norovirus. I should probably Google it and tell you, but I'm too lazy at the moment. So that's another search query you can use to see if you may have norovirus in your community. Google can do that as well. So remember, vomit. A search term that could be a sentinel chicken for norovirus in your community. Of course, if everybody on a Disney cruise starts searching for the word vomit, you know you're on the wrong boat. Speaking of norovirus, chronic norovirus infections are unusual, except in chronic organ transplants, where they can get chronic norovirus infection. And the more intense the immunosuppression, the longer they had diarrheal symptoms. Now, here's what's cool about this particular article. They described 9 patients who had chronic norovirus diarrhea, and they looked at the amino acid sequences in the capsid alignments, and they found that several of the patients had accumulation of mutations over time. One patient had 25 different mutations over a 683-day period, and this patient shed norovirus for 898 days. Not a gentleman I want preparing my salads. But the interesting thing is that the virus was mutating to evade the immune system. So each time it popped a new amino acid, it moved on and escaped the immune system, allowing it to persist, sometimes without clinical symptoms. But this is interesting how you can see continuous viral evolution in immunoincompetent patients, i.e. transplant patients, as the virus stays one step ahead of the immune system. Or maybe this is intelligent design, I don't know. Corynebacterium are a problematic gram-positive rod. They're often poorly characterized, and they are part of the normal skin flora. They are diphtheroids. So you grow out a Corynebacterium, as long as it's not diphtheriae, most people don't care, especially if you grow it in the lung, although I did see one case of Corynebacterium pneumonia in my day, and it was well documented on multiple cultures that were obtained through sterile techniques. This study looked at Corynebacterium pseudodiphtheriticum, which sounds like a battlefield from the Civil War. Now, this consisted of a series of children with cystic fibrosis, and they had an outbreak of Corynebacterium pseudodiphtheriticum, which they pointed out the key thing to this study is that Corynebacterium, well, it could be the real deal, and blowing them off because you do not do good speciation may not be the appropriate thing to do. All these kids had cough and rhinitis when they isolated this Corynebacterium from their sputum, and kids who didn't have the organism didn't have the symptoms. Now, this may not be causality given the complexity of the flora of cystic fibrosis patients. Still, you can't necessarily blow off a diphtheroid. When MRSA is in the household and everybody's having outbreaks, there is an extensive decolonization procedure that I recommend, some of which is kind of sort of based on data. What I recommend to people is that for 2 weeks they take doxycycline and rifampin, that they do Hibiclin showers, that they only use clothes, sheets, towels, etc. at one time, that they flip the mattress, that they get new pillows, and in females' cases at least, and I guess some males, I shouldn't be judgmental, get rid of all their makeup. It usually works, but it's quite an extensive procedure for getting rid of MRSA in the environment. I rarely have a patient come back to see me after such a procedure, either because it worked or they think I'm a loon and don't want to deal with me further. I think the chances are 50-50. Now, this study was slightly less aggressive in eradicating MRSA in the family. This was out of Denmark, and what they did to eradicate staph in the environment was nasal mupirocin 3 times a day. I usually do it twice a day. Chlorhexidine washes for 5 days. I usually do it for 2 weeks. Patients who are carriers receive fudidic acid, which I've never used, in rifampin, or clindamycin for 7 days, and they clean their environment on day 2 or 5. And they found they were able to eradicate MRSA in the environment. So there's a couple options when you try and decolonize the family and the family members. The other thing I sometimes do is, not only do I have the index case do the Hibiclins, but all the people in the family as well as the family pet. Though I prefer autoclaving the animals, most people somehow balk at that suggestion. Go figure. The rule has been with line-related candidemias to pull the line, and there have been studies, the bulk of which have demonstrated that removing the line promptly is important in terms of survival and other outcomes. This may not be the case, however. This carefully done study published in Clinical Infectious Diseases looked at 842 patients with candidemia, the majority of which were not neutropenic. They found that early removal of the catheter on multivariate analysis had no change in treatment success, rates of persistent or recurrent candidemia, time to mycological eradication, and survival at 28 and 48 days. In univariate analyses, and I'll be damned if I actually understand the difference between univariate and multivariate analyses. I'm not smart enough. It was of benefit in terms of survival, but evidently multivariate analysis is more robust than univariate analysis. They conclude that you do not necessarily need to remove the line in patients with candidemia. I will note an important caveat in this study. Patients received either amphotericin lipid formulation or they received an echinocandidin, both of which penetrate well into the biofilms that protect candida in catheters. This is now one of what amounts to 7 trials on candidemia, the best to date in terms of whether or not you should pull the line. I still think that the line should be pulled when infected the majority of the time. Occasionally you will salvage them, and you have to take, of course, into consideration the risk of placing a new line, and some patients are not able to receive another catheter for whatever reason. And despite the large numbers of patients and the robust analysis, there still is a clinician the urge to have source control in patients who are infected. And pulling the line and pulling the source is important given the occasional complications associated with candidemia, such as endocarditis, endophthalmitis, and osteomyelitis. So it's an interesting study, but I honestly doubt it will alter my practice appreciably, and that the majority of patients who have line-associated candidemias, I'm going to say, pull their line. But I will say it with a slight quaver of uncertainty in my voice, and the knowledge that on the occasional patient who I leave the line in, I am justified, at least in this trial, in doing so. Iron is an important bacterial growth factor, and the body works very hard to sequester iron from bacteria. Iron overload states can be associated with infectious diseases of a variety of kinds, including Mucor and Campylobacter infections. This study looked at serum iron levels and liver transplant patients, and they found, interestingly enough, that the higher the serum iron level was, the increased risk of any infection and death in this population. They found just by following the ferritin level as being independently associated with death, as well as the unsaturated iron binding capacity. So another risk factor in liver transplant patients. In prior talks, I discussed the MBL, Mannan binding lectin, not Major League Baseball, the Mannan binding lectin levels of liver transplant patients and how low levels are associated with increased infections. In this case, iron metabolism is messed up in the transplant patient, leading to an increased risk for a variety of infectious diseases. It's important to keep your iron sequestered. This may be of more importance, by the way, in the ICU. I reviewed this literature a couple years ago, but occasionally patients in the ICU get intravenous iron, which is not a bad idea unless they happen to be infected, in which case you could conceivably be fanning the fire, especially if the patient is not on appropriate antibiotics for their infection. And now comes my favorite part of the podcast, the hodgepodge. I like it because I don't bother including the references. You can Google it if you're ever so interested to find the references. I love the term superbug. It's a good panic-inducing description. But there is a new superbug coming from Southeast Asia and India. This is called the New Delhi metallo-beta-lactamase, or NDM1. The important thing about this beta-lactamase is it's found amongst E. coli and Klebsiella, and it makes it resistant to all antibiotics, including carbapenems. The only thing you can treat this with currently or tigacycline and colistin. The development of this particular mutation or gene means the end of the world as we know it. And I feel fine. We are sliding slowly but surely into the post-antibiotic era, and the new superbug is helping that slip slide to death. This study looked at the treatment of uncomplicated falciparum malaria in Bangladesh, and they found that a combination of azithromycin and artemisate was efficacious and well tolerated. Another option for the treatment of malaria. One of the things that marks me as an old geezer is that I don't understand most piercings, nor do I understand tattoos. I do understand their infectious risk. Mycobacterium abscessus has now been reported with tattooing and is a complication of having tattoos. Of course, if your tattoo artist licks their needle, you may be more likely for this. Make sure your tattoo artist is using good technique when he puts on your tramp stamp. Me, I just want a barcode on my forehead. Or maybe 666. Yeah, that's the ticket. One of the things that transplant patients like to do, or actually transplant doctors, is stop prophylaxis in their patients because it's expensive and not without its side effects. This looked at PJP prophylaxis in renal transplant patients and found that patients still went on to develop pneumocystis after their transplant prophylaxis was stopped. They found that important risk factors for the development of pneumocystis were graft rejection. This will never happen in Chicago. Duration of steroid use, use of mTOR inhibitors, and lymphocytopenia at the time of prophylaxis discontinuation were all risk factors for the development of PCP. Curiously, they call it PCP in their abstract, but PJP in their title. The editors of Clinical Microbiology and Infection are not paying that close of attention. There have been outbreaks of pneumocystis, by the way, in waiting rooms of immunocompetent patients. This study looked at pneumocystis in the air of patients with pneumocystis and found that a meter from patient's head, you could find PJP DNA in 80% of patients. This is spread respiratorily, so if you're an end-stage HIV patient, don't be taking care of a patient with pneumocystosis. A case report of cutaneous cryptococcus mimicking cutaneous cellulitis in a rheumatoid arthritis patient. Always beware of the weird-ass organism causing a common infection. Patients who developed pneumococcal meningitis have an increase in their long-term mortality. No big surprise there. Now, there's a drug which I never use, Lamictal, which is used for the treatment of seizures in children and bipolar disease in adults. The new warning mentions 40 cases, that's a lot of cases, of aseptic meningitis associated with the use of Lamictal. It's also called lamotrigine. Is that right? I don't know generic non-infectious diseases. That's just what I get. The Po River, which is a valley in Lombardy. They looked for the presence of Lyme in ticks, and they found Lyme in the ticks of Lombardy. I think the Po River also is the river runs through Italy that was filled with measurable amounts of cocaine. So there's a lot of danger to be had in Italy, but at least the ticks in the Po River Valley, 18% of which have Lyme. There's another rickettsia, and I can't even pronounce this, but it's found in Japan, and it causes a spotted fever. It is rickettsia, Heilongiangensis, spells the very best chocolate. Supercalifragilisticexpialidocious is a better name for this organism. We'll call it Heilongiangensis. I don't even know why I went into infectious diseases. Here's a surprise. This is a major article in Clinical Infectious Diseases. They looked at the association between condom use and HPV in men and found consistent condom use was strongly associated with decreased HPV prevalence in men. I'm shocked. Also, hepatitis B doubles the risk of lymphoma. That's interesting. Hepatitis C, there was an outbreak in an endoscopy clinic in Las Vegas because they used sloppy technique. This is always a problem, and you better have a damn good infection control program to help prevent this stuff from happening. West Nile virus still has not appreciably shown up here in Oregon, but it is now being reported in British Columbia. So while the British Columbians, if that's what they're called, have given the United States Cryptococcus gettyi, we're going to get back at them and give them West Nile virus. Take that, Canada. The H1N1 influenza outbreak that we had was associated with a couple case reports of an acute necrotizing encephalopathy. This report was in the journal Annals of Neurology. In my practice, I saw 2 cases of patients with acute H1N1 who died of severe diffuse encephalopathy at the time of their H1N1. So that was not an unusual manifestation of that particular virus. And that brings us to the end of this Puscast. So now that you're done, take the online quiz, and thanks to Legacy Health, get a half an hour free CME. Now that you're done, you've listened to my mellifluous voice. Go on iTunes and write me a glowing review. While you're at it, visit the rest of my multimedia empire over at moremark.squarespace.com, where you can find my other blogs, my other podcasts, and links to my iPhone application. Because remember, the world needs more Mark Crislip. As always, this is copyright 2010 under the Creative Commons license. The music is by my son when he was 10, improvising on the guitar. Actually, when he was some other age. I forget how old he was. 14? He's 17. He's about to go to college. Can you believe it? He's a senior in high school in just a couple of weeks. I'm getting old. And as always, dare I say it? Yes, I dare. Thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you, in dictation, and goodbye. When my son hears this kind of stuff, he says, "Gee, you're edgy, Dad." High school students, they think they know everything.